Reed, and it is my pleasure to be presenting, or at least introducing, our inaugural Interior Health Emergency Department Grand Rounds. Today we're going to be hearing about frostbite and its management, some details around wound care, and a quick introduction of our new Interior Health PPO for frostbite management. So welcome. And I'm just trying to advance the slide. Bear with me for 1 second. There we go. First off, I'd like to recognize and acknowledge that we're collectively gathered on the traditional, ancestral, and unceded territories of the 7 Interior Region First Nations. This region is also home to about 15 chartered Métis communities, and it's with humility that we continue to strengthen our relationships with First Nation, Métis, and Inuit peoples across the interior. A little note on meeting etiquette. Please note this session will be recorded. Please also ensure that your microphone is muted unless you're asking a question during the Q&A at the end. It just helps minimize all of the distracting noises. With respect to questions, there are 2 ways to ask questions at the end. One, you can use the raise your hand function as outlined on this slide, or you can enter your question directly into the chat box. We will be monitoring the chat box throughout the presentation, but we'll hang on to the questions until the end, just so we don't disrupt the flow of the presentation. And please, please, please complete the evaluation survey that will be sent out at the end. Your responses will really help us to provide meaningful content for future Grand Rounds. So. Okay, so it's my pleasure to introduce our speakers for today. We have 3 speakers who will be talking about frostbite management. First up, I will introduce Dr. Alex Poole. Alex is a rural and remote multidisciplinary general surgeon. He has practiced general surgery in the Yukon for nearly 20 years. His interest in mountain medicine and frostbite in particular has been fostered by having lived and worked in the Yukon, in BC, and in Iceland. And he has been on a mission to modernize Canadian frostbite care since about 2015. We also have Josiane Gauthier today, and she is a clinical pharmacist at the Whitehorse General Hospital in the Yukon Territory since 2010, and she was instrumental in the development and implementation of the Whitehorse General Hospital Frostbite Protocol and its subsequent iterations. She's contributed to recent publications and presented in both local and international conferences on the topic of frostbite, and she spends her free time trail running, skiing, and canoeing in the Yukon wilderness with her partner and her 2 young daughters. And we also have Jackie Geddes joining us today. Jackie is an NSWOC, also known as a wound, ostomy, and continence nurse for the East Kootenay area of the Interior Health region, and she is a member of the BC Provincial Nursing Skin and Wound Committee. So finally, just a quick note before I pass the torch over to Dr. Poole. These emergency department grand rounds are accredited for Main Pro Plus as well as MOC program accredited group learning credits. All right, so I'm going to switch up here and allow Dr. Poole to take over. Oops, I apologize. So many buttons. Okay.
There we go. Thank you, Brandy. So I'm Alex Poole. As mentioned, I'm a general surgeon in Whitehorse. And Josiane and I have been working hard on modernizing frostbite care. Congratulations on developing a frostbite protocol. I think that that'll really help your patients. This is somewhat of an orphan disease, or has been for years, and I'll be the first to admit that the evidence brought to bear on frostbite treatment is as yet thin, and we'd like to participate in making it deeper. And again, it's great that you now have a protocol. I think what sort of started the Interior Health working on a protocol is probably a call that I got in 2017 when out of the blue I got called from Golden, BC, where Nick Tran wanted to transfer a patient from Golden to Whitehorse because we had a frostbite protocol, which reminded me that maybe we should share our knowledge across the country, because a lot of people were doing what I did before 2015, was essentially Google, how do I treat frostbite? I was disappointed to find out that there wasn't a clear answer when I did that. So hopefully we've gone a long way now towards providing a clear answer, and eventually we'll gather more evidence so that there's a a larger body of evidence behind what we do. Because I work in Whitehorse, it's cold, we get adventure athletes, so we do see frostbite. And as we speak, we have probably 2 patients on iloprost in the hospital right now. Next slide, please. So all of the pictures that I'll show on my slides are from my patients. They have given me permission to use the photos for publication as well as teaching purposes. The only financial disclosure I have is that we are now part of a study and we have a grant through the Northern Ontario School of Medicine with some colleagues in Ontario. And otherwise, I have no conflicts. Next slide, please. So I'm going to concentrate on the hospital care of frostbite today, and to know the rationale for how we progress from the initial evaluation of the frostbite patient to the treatment that we do, we need to understand grading and how it establishes prognosis. And that's what we're going to use to decide what care that we bring to patients. And then I will go through the pathophysiological rationale for the advanced care that we do offer these patients. Next slide, please. So what's a little different about Whitehorse is that we have a disproportionate number of adventure athletes that get frostbite compared to urban centers. And so we do get the advantage of getting some young, healthy patients that their only injury is a frostbite injury and it's their first injury. And this is an example. This is our very first patient that we used our protocol on, and this is a Polish runner who was leading the Yukon Arctic Ultra at the time, which is a 700-kilometer race that they intentionally schedule for the beginning of February so it can be as cold as possible. And as you can see, what he's wearing I sometimes joke that from a frostbite doctor's perspective, it's a perfect scenario. We get minus 35 conditions in February, and we get a plane load of spandex-clad Europeans that want to run 700 kilometers. So this is why we've developed an expertise in frostbite. Next slide, please. So these are his hands, and after this discussion, I'm hoping that you'll be able to look at this and say that this is, at least on his 5th finger, a grade 3 frostbite injury. And I'll go through the rationale for why we call that a grade 3, and that it has an underlying amputation rate of possibly as high as 83% as a natural history of the disease. This is without advanced treatment, and we'll talk a little bit about what we've done to change that. Next slide, please. So this is where we started. So this is the picture on the left of someone with a significant frostbite injury and their ultimate outcome on the right. And I probably don't have to convince you that they may lose yet another toe given that picture. And we thought, well, can we do better? And this is what I mentioned, that I started a slight internet search and was somewhat frustrated that I didn't get a clear answer. And so we developed some goals for this. Next slide, please. So ultimately, we were hoping that we would take someone as the left-hand side picture with very significant grade 4 frostbite to, in that picture, 8 out of his 10 fingers, and get the ultimate outcome, which is down in the picture on the right, which is a complete recovery. So what we started with, we looked at our data, we did a literature review, we contacted what experts we could throughout the world, and we started to try and develop our protocol, which the fruits of that labor is a lot of what you'll be using now. Next slide, please. So really, what we're talking about here is extremity cold injury. We're talking about primarily fingers and toes is what you're going to see, and this is what we're giving the advanced treatment for. And there's really 3 stages of this injury as it occurs. There's the pre-freeze stage, the freezing, and then the thawing or reperfusion injury, which is where most of the vascular injury occurs and ischemia comes from. There's someone out there who may not be muted. If everyone could mute, that would be awesome. Thank you. Next slide. So I find this is an interesting concept as someone who spends a lot of time in the outdoors. This is the pre-freeze phase, and this is what you're feeling. And these numbers are approximate. They do come from a variety of sources, but this is what the temperature is on the surface of your skin. And this could very well be the surface of your skin within your gloves or mittens or your boots. But the first sign that you're getting cold is you develop pain. I think we've all experienced, you start to get pain in your fingers when you're out in the cold weather. And the surface of the skin temperature is about 15 degrees at that point. Then when you become numb, it's approximately 7 degrees Celsius, and the peripheral nerves are not functioning well at that point. The problem with frostbite is you get no other warning sign between when you have the numbness and then when you get frostbite. There's no symptom change between numbness and frostbite. You're insensate at that point. So when you become insensate at the very beginning, that's probably a good hint that you should change your situation, either put another layer on or get out of that cold environment. Because unfortunately, those people don't recognize that they're getting frostbite because they gradually cool with no symptom change. Next slide, please. Okay, so what happens with the freezing injury? So now we're talking about frostbite. Next slide, please. It can be quite subtle at first to tell if somebody has frostbite. Their hands or their toes may look abnormal. They may hurt if they've started to rewarm already. Often they'll be pale. You may see cyanotic changes early on, or they just look gray. Things like blisters and edema are a post-rewarming phenomenon and can progress over the first day or two. Next slide, please. So it can be difficult to tell early on. Next click, please. So this is the post-thaw picture. So this patient has had cold exposure to a significant extent, and this is what his hands look like immediately after the post-thaw. And you can see his fingers are a little dusty, some of them right down to the MCT area, at least on the volar surface. And then this is what he looks like 24 hours later. Next clip. See, it's not so subtle now. His entire hands have ballooned up into blistering. So this is a very significant frostbite injury. Next slide, please. And I think at 48 hours, you can agree that he certainly has tissue at risk. So this can be quite difficult to tell early on clinically. And I think that eventually it would be nice if we could correlate clinical findings with things like bone scan to really look at deep perfusion, so that those of us that don't have access to advanced imaging early on would be able to tell clinically exactly what the injury is. But these pictures that you're looking at now is entirely why that we treat grade 2s aggressively, and I'll talk about the different grading, is that I can't tell for sure that a grade 2 is not going to look like a grade 3 at 24 hours. And as Josiane will go into a bit more detail, warm ischemia time is important. So the faster we get these patients treated, the better. Next slide, please. So what is the pathophysiology of this injury? Next slide, please. So there's initial freezing injury. Now for frostbite, it's mostly extracellular ice crystal formation, because it's a gradual freezing injury. If you were to dip your hand in a vat of liquid nitrogen, you would get intracellular ice crystal formation, which is a different injury. But most of the time with frostbite, we're talking about extracellular injury, which really cause osmotic changes because of the changes in concentration. And the cells will shrink. You will get some cellular enzymes that fail and a bit of sludging in the vasculature, possibly some mild endothelial damage, but this is a recoverable phase. This is not where most of the injury occurs. That occurs in the thawing stage. Next slide, please. So the hallmarks of the thaw injury are vasoconstriction and thrombosis. As you can imagine, in small vessels, these are things that lead to ischemia. And this is where we are directing our aggressive treatment. And that is thrombolysis or vasodilators, which we'll talk about. And some of that as well is metabolites that are particularly nasty of the arachidonic acid pathway. And we'll go into that in a bit more detail. Looking at this slide, or the graphic part of this slide, what's important here is that the blister that we see in this picture is a superficial blister, and that's got thromboxanes in it, which are potentially bad actors for vasoconstriction and ischemia. Clear blisters are different than hemorrhagic blisters, and clear blisters are a superficial injury. Hemorrhagic blisters are a deep subdermal plexus injury, and so they are more significant and can be a surrogate for cyanosis when you're trying to diagnose these patients clinically. Next slide, please. So the other thing to know is that refreezing is a disaster, and that's what happened to this patient eventually. They probably had a secondary refreezing injury, and that doesn't recover well. If you can imagine, in the burn units, they'll bank skin that they will actually put in a cold freezer, and then they can use that as a skin graft. So the actual frostbite injury to initially doesn't change the collagen makeup of the skin. and the subcutaneous tissues, but the refreezing injury can break all that down. So refreezing is a disaster. So once these patients are warmed up, it's really crucial, at least in the early phases of the first few weeks, that they don't have another freezing injury. Next slide, please. So what about grading? And this is really important. So this is moving beyond classification and towards prognosis. Next slide, please. So what's important is historically people just borrowed the classification system from Burns, which is not entirely accurate. And next click, please. And it's probably sufficient, like in Burns, to simply, you can just click a couple more, thank you, Brandon, is to look at this as a superficial or deep injury. Now, this doesn't view towards prognosis, but the superficial injuries are the clear blisters, a bit of erythema, some numbness, but the deeper injuries are the hemorrhagic blisters or the cyanosis. Next slide, please. So one of the fundamental changes in frostbite over the last few decades is this recognition that this is an ischemic peripheral injury that moves proximally and their prognosis gets worse as it does that. And we have this work done in Chamonix by Dr. Cauchy and his colleagues where they looked at bone scans. So the picture on the right is the patient's ultimate outcome with amputations and an x-ray thereof. And the picture on the left is a bone scan done in 48 hours. And those dots at the very ends of the fingers are markers, but you can tell between most of the hand and those dots, there's no blood flow. And they found that these bone scans would actually predict the ultimate outcome or amputations that were required. And so using this, next slide, please, they developed this grading system that we all use now, and it's grades 1 to 4. There is no grade 5, though sometimes I wish there was now that we're getting better at treating these patients, because certainly occasionally we do see patients that have frostbite beyond the wrists or ankles. But for most of our purposes, we're talking about grade 1 to 4. 1 really is no cyanotic change, or really just an injury to the fingertips or tips of the toes. And their natural history, using that Chamonix bone scan data, is 0% amputation rate. Beyond that, there's a real amputation rate. So grade 2, which is cyanosis beyond the proximal or the distal phalanx. Now, again, these are their numbers, but you could say 39% or certainly a significant or real amputation rate. As it gets more proximal, the amputation rate gets higher. And those proximal changes are cyanosis or hemorrhagic blistering, if you can't see the cyanosis very well. Next slide, please. So the basis of treatment of frostbite is the rapid rewarming, early movement physiotherapy, OT, wound care, hydrotherapy, and the advanced therapeutics that we'll talk about. What hasn't changed is that you can really delay surgery as long as you can. If there's no underlying infection, you can wait and let things declare over time. But we're really trying to get these patients to avoid surgery entirely if we can. Next slide, please. So just a comment on rewarming. We do get asked about this a lot. Mills in the 1960s, an orthopedic surgeon in Anchorage, Alaska, did some early studies that showed evidence that the best rewarming is a rapid rewarming in hot water. The next best is probably slow, spontaneous thawing. That's better than keeping them cold, for instance. And water temperature anywhere between 37 to 39 degrees, which is often what comes right out of your tap. But if you don't have a way of measuring the temperature, test it with your own hand. And if you can tolerate it for 30 seconds or so, then that temperature is probably warm enough, but not too hot. It's great if you don't have a heating element, but rather have an insulated tank so they don't get a secondary burn injury if they rest their foot or hand on the heating element. And this is what we have in Whitehorse, and it seems to work fairly well for us. Next slide, please. So now Josiane's going to talk about the pharmacological treatment of frostbite, and in particular how it pertains or is directed by the prognostic grade that we have given these patients clinically.
Okay, thanks, Alex. So I'll go over the different treatment options. I pretty much went through every single publication on frostbite, trying to find the best available evidence. I'll try to summarize here what is to know about pharmacologic treatment. Next slide. In order to understand treatment, we need to understand what's going on in the blisters after rewarming. So back in 1981, researchers in Chicago aspirated the blister fluid of patients with frostbite. And what they found was that some prostaglandin and thromboxane that cause vasoconstriction and platelet aggregation were elevated. They suggested that it was those substances that were responsible for the vascular changes that we observe after rewarming, leading to ischemia and death of the tissue. This is the famous arachidonic acid pathway and the bad substances in question. You can click twice here, the thromboxane B2 and prostaglandin PGF2 alpha. Researchers also found that PGE2, a vasodilating and anti-aggregating substance, was low in those frostbite blisters. This led to earlier studies in frostbite treatment, looking at aloe vera and aspirin. Next slide. Aloe vera's potential in frostbite was first studied in vitro and in animals. Researchers found that aloe vera inhibits thromboxane B2 and also limits the production of PGF2 alpha. It also has antimicrobial and anesthetic properties. It improved reperfusion and tissue survival in animals with burns, so they went on to study it in frostbite. In rabbits with frozen ears, there was more tissue survival with aloe vera compared to control. In another animal study done later, they found that aloe vera accelerated wound healing compared to antibiotic creams or silver sulfadiazine. It was also studied in frostbite patients in 2 studies in the States where aloe vera was incorporated to a frostbite protocol that included ibuprofen and antibiotics. It improved outcomes compared to traditional treatments. They used a water-based extract of aloe vera at 70% in a cream, in the form of a cream applied every 6 hours. And the Dermade aloe cream was the product that was developed at the University of Chicago back then. We use an aloe vera ointment in a Vaseline base from Convatec. But I just learned last week, actually, that the concentration of aloe vera is in fact very low, and the product will be discontinued by the end of the year. So we'll be looking at finding a replacement product. What I would be cautious with using after sun products because they often contain alcohol or local anesthetics such as lidocaine, and they can be very sticky. Next slide. NSAIDs block the arachidonic acid pathway and the formation of the bad thromboxane and prostaglandin. So pharmacologically speaking, it's logical that they can help with frostbite. Aspirin specifically has been studied in animal studies with animal with frostbite, and it improved tissue survival compared to control. Ibuprofen has been incorporated to frostbite treatment protocol since the 80s in the States. And in one first observational study, it improved outcomes it improved tissue survival. In another case control study done in Detroit, the patients treated with ibuprofen as part of a protocol had 5 times less amputation and decreased hospital length of stay compared to case controls or patients treated with various methods of treatment. Ibuprofen specifically has been popularized by Hagers and his colleagues in the 80s. They said back then that ibuprofen is more active against thromboxanes than other prostaglandins, and that ibuprofen is more specific in inhibiting the bad prostaglandins. And this is true. Technically, ibuprofen can preserve the good prostaglandin because it only inhibits the COX enzyme reversibly, and the enzyme can regenerate itself between doses. In theory, a low-dose aspirin would have the same effect, so low-dose aspirin at 81 milligram, but we don't have the answer to that question yet. Next slide. The first treatment that really addressed the thrombosis that happens after rewarming were tissue plasminogen activators. They break the clots in the extremities and help restore perfusion to prevent ischemia. They work by binding to fibrin in the thrombus and converting entrapped plasminogen to plasmin. The most significant risk with any thrombolytics is bleeding, and it can be serious. For that reason, thrombolytics are often, well, they have a long list of contraindications, and they're often, they often have to be given in the ICU for monitoring, etc. In Frostbite, several thrombolytics have been used, but the one that is most commonly used is alteplase. Next slide. Alteplase was first used in the 90s, but the first publication of its use came out in 2005 from the researchers at the Hennepin County Medical Center in Minnesota. Since then, I counted over 30 publications using thrombolytics to treat frostbite. Most were case reports or case series. Only a few were controlled, and they were all retrospective in nature except one RCT. However, altogether, they gathered data over 500 patients with improved outcomes with thrombolytics. In most studies, patients with frostbites were assessed by either angiography or bone scan after rewarming. And in those patients with decreased perfusion, where amputations was likely, alteplase was generally effective at decreasing, at least to some degree, the risk of amputation. Next slide. So in earlier studies, alteplase was always administered by intraarterial infusion, preceded by a vasodilator. And this was usually done by a radiologist assisted with angiography. And this was definitely a barrier for us to the use of thrombolytics because, it was difficult for us not having radiologists on site. Wherever there's no radiologists on site, such as smaller hospital or remote locations. In more recent years, alteplase has been given with success IV, and a good systematic review has looked at the efficacy and risk of the two different routes of administration. And regardless of how thrombolytics were administered, it was effective at saving digits that would have otherwise been amputated, and the complication rate was similar. In that systematic review, factors that were associated with treatment failure were delayed presentation, multiple freeze-thaw cycle, and delay in thrombolytic initiation. Next slide. On that last point, one of the most important factors that influences response to thrombolytic is how soon it's given after rewarming. And the team from Minnesota verified this in a study in 2017. Amongst patients treated with alteplase, the time between rewarming and thrombolytic therapy was longer in those who required amputation. And regression analysis showed that for each hour of delayed treatment, there was an increased risk of tissue loss by 30%. And so alteplase should be given as soon as possible after rewarming, ideally within 4 hours, with benefits up to 12 hours post-rewarming. Next slide. Heparin is generally given during or after thrombolytic, and that's because fibrinolysis can have procoagulant effects. We now use enoxaparin because it can be given subcutaneously, and it's simpler than an infusion. Enoxaparin also has some theoretical advantages or pharmacologic advantages over heparin. Heparin cannot bind to the thrombin that is bound within a clot, and that can promote more thrombogenesis. Enoxaparin has anticoagulant effect through the factor 10A, so it has advantages over heparin for that reason. It also has less risk of heparin-induced thrombocytopenia. Finally, warfarin or clopidogrel have also been used in some centers upon discharge, but there are barriers to using those. Next slide. Now, iloprost, it's been key for the treatment of our patient. It's a potent vasodilator, which addresses the vasoconstriction that happens after rewarming. It can also improve the thrombolytics efficacy by improving the access of the thrombolytic drugs to the extremities. Different vasodilators have been studied or tried over the years, but only iloprost has compelling evidence in frostbite. It's not only a potent vasodilator, but it also inhibits platelet aggregation. It enhances fibrinolytic activity by releasing endogenous tissue plasminogen activator, and even has cytoprotective properties. Next slide. To understand how iloprost works, we can go back to the arachidonic acid pathway. Prostaglandin PGI2, also called prostacyclin, is a strong endogenous vasodilator. You can click twice. And iloprost is a synthetic analog of PGI2. Next slide. Iloprost was first studied in the 90s. An Austrian physician reported treating his frostbite patients with iloprost, and they all fully recovered. Then it was not until 2011 that the next publication came out. Dr. Cauchy and his team in Chamonix published the only prospective randomized controlled trial on the treatment of frostbite. Their patients treated with grade 3 and grade 4 frostbite, treated with iloprost at 0% amputation, and their patients treated with iloprost and alteplase had 19% amputation rate. Since then, there were 8 publications reporting using iloprost for frostbite. Alex and I published a case report describing our experience treating our first 2 patients back in 2016. And then came a few publications from Europe. They were small case series, case reports, or retrospective observational studies, but totaling over 100 patients. We just published our 5-year experience last year, reporting data on 22 patients treated with iloprost. Next slide. The publications in the last few years brought to light 2 very interesting aspects of iloprost. In some cases, it appears to be effective in patients that had minimal response to alteplase. It also appears to be effective up to 72 hours after injury, and it has less contraindications than thrombolytics. It is well tolerated, and what we see most commonly are headaches and flushing. It can also be used in grade 2 to 4, as opposed to grade 4 only for thrombolytics. Next slide. Now, most of the research that we have on frostbite wound care goes back to the work from Dr. Mills in Alaska in the 60s. Back then, they compared an open method to a closed method. In the open method group, they put absolutely no dressing of except for small pledges of cotton between the digits to avoid maceration. And in the closed method group, they used ointments, occlusive dressings, moist dressings, and even plaster. And there were more amputation in the closed method group compared to the open method group, probably explained by a rate of or risk of infection. And the results from this study still dictates our wound care approach today. We use non-adherent contact layers, gauze to provide padding and protection, and bandage rolls and tubular net bandages to hold everything together. Next slide. I often get questions about other topical products. Antiseptics have been used since the 60s in the rewarming water, but there's no strong evidence that that cleansing the wounds per se increases healing or reduce infection. Silver nitrate solution has been used in the 80s and 90s in Alaska, but it was very messy to use. Silver sulfadiazine, a combination of silver and antibiotic, has been used anecdotally in frostbite. Unfortunately, even in the treatment of burns, the efficacy of silver sulfadiazine is controversial, and there are some concerns that it may have cytotoxic effects and may delay healing. And as to antimicrobial ointments, they are probably unnecessary because frostbite wounds generally do not become infected. Aloe vera is really the only topical product that was actually studied in frostbite, including animal studies. So I would say it's the only product supported by some evidence. Next slide. So Alex and I developed our frostbite protocol in 2015, and we developed an algorithm as well as order set to streamline frostbite treatment at our hospital. Next slide. The first steps include rapid rewarming in hot water, and then visual grading of the severity using the Cauchy classification that Alex described earlier. Next slide. In grade 1 to 4, we do hydrotherapy, we give aloe vera and give ibuprofen. In grade 2 to 4, we give iloprost as a daily infusion over 6 hours for 5 days, if patients present less than 72 hours after rewarming. And in grade 4, we give alteplase in addition to iloprost if patients present less than 24 hours after rewarming. Next slide. So the first barrier that we encountered when we first heard of iloprost was actually getting it. So unfortunately, it's not commercialized in North America. So we had to request authorization to use it from Health Canada Special Access Program. So the drug company is importing the drug from Germany and providing the drug free of charge to the hospitals who get special authorization from Health Canada. Next slide. So to get iloprost, we need to complete Form B for future use, so we can have the ampoules in stock when frostbite patients present to our hospital. Next slide. So we published our 5-year experience using our protocol in a CMAJ Open. In our grade 2 and 3 patients, we had 0 amputations. And in our patients with grade 4 frostbite, where amputation risk could be as high as 100%, we had 50% salvage rate. Next slide. What we've also saw is that since the implementation of our protocol, we reduced the time from presentation to treatment. And we know that this is critical for the drugs to be effective. So having a protocol and order set really helped. We also offered education to our hospital staff as well as community health centers across the territory. And even in Whitehorse, we don't have that many cases of severe frostbite a year. So having a protocol and doing more education like this certainly helped. So we welcome your questions.
Wonderful. Thank you, Josiane, and thank you, Alex. I think prior to delving into the questions, we'll save them until the very end, and we'll just carry on with the remainder of the presentation. We have Jackie Geddes up next. So I'm just going to pull up your presentation, Jackie. Bear with me for a second.
So I want to say thanks for inviting me. You won't see my face on the screen because my old IH laptop, very ancient, doesn't play well with MS Microsoft Teams. So I don't want to fall off the end of the internet world here. So hopefully it works through my short presentation here. And is Rochelle, is she on? I was hoping one of my colleagues would be there in case I failed.
No, Rochelle's not on that I can see.
Okay. Okay, hopefully I get through here. I don't have the warning flashing at me yet.
And just a second, Jackie, I've almost got your presentation up. Just bear with me for 1 minute here.
This is quite
Okay.
timely because our provincial skin and wound committee was actually working on a quick reference guide for frostbite when we heard that IH was also working on the pre-printed orders. So great that we can come together like this. And
Can you see my presentation, Jackie?
no,
Is it up?
Not yet.
Nope, sorry. Okay, apologies. I was really testing my tech abilities today. Just a minute here. Okay. Okay, how about now?
Nope.
no, it's downloading.
Interesting.
You've got the white horse in the background of something, Brandy.
Okay, I did close that one, but obviously it did not like that. So bear with me, everyone. I apologize. I will
It's a lot of juggling.
try one more time here. What do you see now?
That's it. We just
There we
need
go. You
the
go to
Right.
slide.
slide.
Okay,
Yeah, you can go to slide
Okay.
3. the
very
third one.
good.
So strategies, oops. So this is what the reference guide, this is the head of it. It's going to be made by all the health authorities in BC and then wait for IH Provincial Practice Office to approve it, and then it'll be on our IH website. You go to the next page. Some of this is covered, but just what does a nurse in emerge need to know? Well, I think the hardest thing is figuring out how we're going to rewarm these limbs. So once the patient is stabilized in their hypothermia and has something for pain management, because it can be very painful, remove the jewelry. And if there's frozen like socks or something adhered to the skin, you would want to leave that on until you thaw that in the tub. So we're just we don't have the fancy little gadgets in all our rural hospitals. So you're kind of gonna have to make do with what you have. Buckets, basins. Rochelle had a great idea of the small insulated coolers. So the emerge nurse isn't trying to constantly refill with warm water. So you want your 39-degree water that Dr. Poole described how to test with your chlorhexidine alcohol, so 30 mils per liter and about 30 minutes. So yeah, and then you'll let that air dry. Don't rub it dry. Go to the next slide. I'll be very quick here. So topical dressing. So as Josiane mentioned, there's the bad prostaglandins and stuff in the serous-filled blisters, so they would be deroofed to get rid of that fluid in there, but not the blood-filled blisters. And then the aloe, we're still looking at a replacement for the Aloe Vesta. Both IH and the province of BC are looking for a product with a higher percent of aloe. So by next frostbite season, we should definitely have something. And as with most ointments, you want to put it on about 3 millimeters thick. And what I found the easiest way to put an ointment or gel on a moist wound is to take a tongue depressor and you actually butter that ointment or gel onto your adaptic or your contact layer, whatever you're using for your contact layer. And IH, we're going to recommend adaptic provincially as well. And then you can take that contact layer and wrap it around all your digits and put it on all of your frostbitten areas and mottled areas that would benefit from the aloe vera. And then, yeah, then after that, we can go to the next slide. After that is when I would put the gauze between the digits if you're going to be wrapping all the digits together. So that shows in the toe there. It doesn't show the adaptic on there, but it just shows that you're putting your gauze in between your toe. And then it's a very simple dressing of just layers of gauze. Yeah, it's not a very complex dressing. That's why I don't have a lot to say today. So yeah, I think that's about it. Continuing care when you're sending them up to the unit, you want to make sure their limbs elevated to increase the risk of bad edema, protect those limbs from trauma. weight bearing if frostbite goes beyond the distal toes, and then it'll be a daily dressing change. And that's basically it. It's quite a simple dressing. So that I don't have much to say. So yeah.
Wonderful. Thanks, Jackie. No, that's perfect. That's very helpful. Finally, I will just briefly introduce you to the new Interior Health Frostbite PPO that's been developed. This is just a screenshot of the first page of the order set. I believe it's at least 4 pages. It's quite comprehensive. It has all the information you'll need to manage your frostbite cases. It's really not important to remember the details of the PPO right now. It's simply to note that it exists and it'll soon be ready for use in the emergency departments to help you provide the best care for your frostbite patients. So stay tuned. This will be coming and it will be incredibly helpful and contain all the information that's needed. So I think we're at the stage where we can open it up to questions. So I might toss this over to Erin to run the questions, and then I will chime in at the very end. And I will sign off right now. Erin, you can take the mic.
Super. Thank you very much, Brandy. And thank you, Alex, Josiane, and Jackie for contributing to this presentation thus far. It's been fantastic. And maybe Brandy, I can just ask you to stop sharing so we can see each other a little easier for those who may be asking questions. I'm Aaron Zydoff. I'm the medical director with the Emergency Services Network here in Interior Health, just for introductions. We've had a few questions come through the chat, and Alex has already been on a couple of them. One of the pieces I'll just speak to, Bruce Davidson had asked a question about where iloprost will be available. I think Alex already spoke to its being available since 2015 here in Canada, but it is currently available and stocked in Fernie, Golden, and Kelowna. And we, as a part of this process of developing this protocol, are working with pharmacy to create a bit of a spoken hub model so that we can have access more to our northern communities as well. So that is being developed, and the access, as Alex has mentioned, is free at this point through a special authorization program, and it will be that process will be done by our pharmacy team ahead of time. So it will be much easier to access, and they will, retroactively complete the forms to restock the pharmacy. So a little bit on that. Alex, maybe I'll pass this one on to you. There's a question about imaging, and just wondering, Raz had asked, Dr. Mula had asked about just speaking to a little bit more about the bone scan and its purpose in current management of frostbite, or are there other, you mentioned briefly some other advanced imaging. Was there any other pieces of imaging which are helpful or not?
Well, that's a great question. So the data is on bone scans, which is what they did in Chamonix, and I think Minnesota uses them quite a bit too. Unfortunately, the original data is at bone scans at 48 or 72 hours and not pre-treatment necessarily, and so people are using it for that. Because fundamentally, if you can tell that the bone is not perfused, then you have a significant ischemic injury. Ultrasound has been tried. At this point, the detail is probably not good enough on small ultrasounds to know about the digital vessels and know if there's good perfusion that needs to be reversed. MR and CT angios have both been tried, and at this point, they're somewhat problematic. CT PET scan's been tried as well. What I have found might be useful, and we published an image of this recently, is fluorescence, which is excitation light using fluorescence, which is an inert intravenous injection that people will use for flaps, for instance, in plastic surgery. And so that may be easier to use down the road. But I think ultimately it would be nice if we could study in larger centers that have access to all this advanced technology, how those of us that don't have it, how we could clinically correlate what that advanced imaging would show us. In other words, if I look at an ischemic injury that looks cyanotic to the knuckles, if somebody has done a study elsewhere with large volume of patients to know what a bone scan would show in that scenario, then I can grade it properly. And so that's why it's good that the rural communities stay involved with this so that we can correlate those two.
Super, thank you. The another question that had come across was, what about grading for other places for frostbite, such as the nose or the ears or other possible exposed skin?
I don't know. That's an excellent question. So there's no way on the ear, I suppose you could circumferentially grade it as it goes in. Closer to the center of the ear would be worse, but there's no data on that. So what I use as a surrogate in that scenario, if you see hemorrhagic blisters, you can call that a grade 3, and I would treat it accordingly. Now, we as yet have not treated isolated ears or nose injuries, because usually those have come concomitant with fingers and toes at the same time, so we're treating those. But that's an excellent question, is how we should grade those. And obviously a bone scan of the ears would probably not be that useful, so I'm not entirely sure. But the short answer is hemorrhagic blisters are a surrogate for grade 3 or worse.
Great, thank you. We have another question. Adam, you can unmute yourself and go ahead.
Thanks, Aaron. Thanks for the talk. It's been great so far. My name's Adam Watchorn. I'm a merge doc in Golden, and the few cases we've had recently, we've had trouble pulling the trigger on iloprost, and I'm curious about what your threshold of distal cyanosis is. We've had a few patients who've had like just a touch of cyanosis on the tip of their finger, and like 4 hours after. And would you go ahead and treat that right away, or would you? We often struggle with that, and we ask ourselves. And then I think I called you one time as well, and I think you directed us to just use it, but we've always struggled with that here.
Yeah, which is the big reason we went to treating grade 2s. We didn't treat grade 2s initially, because it's one thing to think a grade 1 is a grade 1, the next day decide it's a grade 2. But if you thought it was a grade 2 the night you saw it, and then the next morning it's an obvious grade 3, you'll sort of regret not treating it aggressively, because it can be hard to tell. And so if it's simply a toe, one toe or one finger that's really just the tip that's cyanotic, I mean, that's completely going to recover. It's the same with an amputation. If the amputation of your fingertip on the volar surface is less than a centimeter, it probably doesn't need a skin graft. It's going to close secondarily on its own. You can sort of think of it that way. But I tend to be aggressive. If I have any doubt that this is worse than I think it is, the iloprost has been so well tolerated by our patients that I'm pretty aggressive with it. So if I'm on the fence, I'll treat them. And probably those of you who are now starting a protocol, our experience has been that it's so well tolerated that we usually treat these patients, if they're ambulatory and they have a place to go, we treat them as outpatients after their first treatment. So they'll come in, they'll get their 6-hour infusion for 5 days in a row. At that time, they'll get their hydrotherapy, their OT-PT, and do their dressing changes and then go home. They don't even need to stay in the hospital. They're just there for the infusion itself.
Super, thank you. Another question in from the chat from Dr. Justin Kopp. Do you change your criteria at all for thrombolytics based on which digits are involved? No. I mean, fingers versus toes? Yeah, I'm more aggressive with fingers. So my fence is different if it's fingers than toes, frankly, because you really want to save the fingers. But no, I treat both fingers and toes with thrombolytics if they're a grade 4 and they're within 24 hours of rewarming. Okay, awesome. And have you, another question came forward, have you, in your experience with iloprost, have you had any difficulty with complications, hypotension, patients not tolerating it, or in your case mix group?
No, I mean, that's a good question. I mean, Josiane would have data on this as well. 50% of our patients had headaches, which is really the most common. That's usually a dose related. Often we've been able to turn the dose down, give them analgesic. I think we only have one patient who essentially wanted to quit the iloprost infusion because their headaches were so bad. And it's the same with temporary hypotension, but we've had no significant problems. Everyone's more or less been able to tolerate their treatment. So we've been surprised how well it's tolerated, which is why if the patients are capable, we've gone to outpatient therapy for this.
Okay, super.
And,
And Josie,
and
go
as
ahead,
yeah,
Josie.
go ahead. As Alex
Oh,
mentioned, it's rate dependent. So it's an infusion, and we start the infusion at 10 mils an hour, and we slowly increase the rate, and that seems to improve tolerance. And if they have side effects, we just go back by 10 mils an hour or go down by 10 mils an hour, and then usually their symptoms resolve, and then we can resume increasing the rate. And then by day 3, 4, and 5, we can actually start the infusion at max rate with good tolerance. So it is really related to the rate of the infusion.
Thank you. And Josie, another question maybe I'll put to you. We do have this in our protocol, but just I'll let you speak to it. Any indication on how long to use enoxaparin following the thrombolysis with alteplase?
Yeah, that's a good question. We use it for 72 hours, but there's no good data. We're just extrapolating experience from STEMI and other indications, but I would do 72 hours.
Super, thank you. And maybe to Alex, back to you. Do you notice a fair bit of difference between athletes or patients with possible comorbidities, peripheral vascular disease, or substance abuse related injuries or triggers that would that change your management at all, or not?
The hardest ones are the people that you suspect may have had recurrent frostbite injuries. We have maybe a couple that come in every winter with frostbite injuries, and they're unlikely to do well, which I think is partly what's frustrated people who've treated frostbite in urban centers, is they're getting a population that may have had the injury before. From a statistical point of view, we didn't find any relevance to any of those in our small series of 22 patients, though alcohol use at the time was reaching close to statistical significance. But do the athletes do well? Yes, they do, and I think because they're otherwise healthy. But we haven't statistically. That's something that we need to study. It would be great if beforehand, that may even be beyond grading, to tell you how you should treat some of these patients if you know what their risk factors for amputation are different than other people.
Super, thank you. And we have a comment from Al. I think Al must be a salesperson from Bed Bath & Beyond there. You can see that in the chat there if you like, but apparently there's a good warming device at Bed Bath & Beyond. So and then one final question, do you find a use for gabapentin in these patients? Obviously pain control is a significant challenge. Josie Ann, maybe I'll put that one to you. So
we don't use it currently in the acute management of frostbite. I've dig into the literature for sequela of frostbite, and a lot of patients do have permanent numbness or decreased sensation or even difficulty tolerating the cold. And there is some data looking at using gabapentin to treat those long-term effects of frostbite. In the acute management of frostbite, I don't think there's any value. Maybe as an adjunct in the pain management, we use opioids for pain, and the NSAIDs, which have the dual effect of treating the pain and being providing added value or pharmacologic action as well.
Super. Well, thank you. I'll close it off on there for the questions, but thank you again, all three of you, Alex, Josie Ann, and Jackie, and Brandy, for starting us off in the with this first inaugural Grand Rounds. We are looking forward to future Grand Rounds, and a reminder, there will be a survey coming out. Please take the time to give us feedback so we know where we can go with our next series of Grand Rounds and make them relevant to what you're doing. And also just don't forget about the CME credits as well. You can claim those also. So thank you again. Very much looking forward to future work that you both are doing in this area. We'll stay tuned. So take care, everyone. Bye-bye.
Thank you.
Thanks, everyone.
Thank you.